Thanks for the invite, Grigoris and everyone here. My name's Thomas Keeble. I'm a cardiologist in the Cardiac Centre in Essex, and we've used continuous thermodilution for about the last 6 years in a variety of clinical scenarios. And my task is to tell you about the best method for invasive microvascular assessment. So I would call the continuous thermodilution the gold standard. I would call bolus the bad, and I would call Doppler the ugly. If anyone's used Doppler historically, then you'll probably understand why that is. So I'm going to talk about the ugly first. It's a stiff, challenging wire. It's technically difficult sometimes to obtain Doppler envelopes, and the poor hardware data interface is a bit of a disaster. Now, don't get me wrong, they are developing another one, and it's due to be in the EU, I believe, at the end of this year or next year, and maybe from a research perspective, that will be interesting. It's not available currently, and everyone on the planet doesn't have one, so we don't have any anymore. There's none that are still in date or sterile. Bolus thermodilution, you saw a very nice demonstration for Grigoris. It is quick, it is easy, it is cheap, and it has, to be fair to it, the most robust clinical data and outcomes. So we shouldn't just throw the baby out with the bathwater. I tend to do CFR, IMR in every case that I do FFR, which is every case that I do physiology. So it takes 2 to 3 minutes. It takes the same amount of time as doing an FFR. So when you get quick and slick at it in your lab, you may as well just use CFR, IMR all of the time. Limitations are it is operator dependent, has poor reproducibility, as you have seen, but when you know what you're doing, you know why it's not reproducible, and so usually you can improve matters. And I think, as you saw in that case, the CFR was 5.5, so often you get numbers of 6, 7, 8, which when you do continuous thermodilution, you know are not true. So continuous thermodilution. It is operator independent. It gives you an FFR, which is usually about 0.03 lower than adenosine. It gives you volumetric flow. It gives you absolute resistance. But it is costly, probably costs about 550 euros per catheter, and is non-automated. So you do have to move these bars to know where you want to measure the pressure. So this is from Carlos and the Core House team from their beautiful physiology course, which if you have a chance to go to the physiology course in April, it's a wonderful course. You put the pressure wire X down in the LED, just like Grigoris showed. You then advance the ray flow catheter, which, as he showed you, has 4 holes that spray saline from an LV pump in mils per minute, and that's really, really important. If you do it in mils per second, like an LV gram, you will obviously explode the left main stem or the LED, so it must be in mils per minute. And the calculation is actually extremely simple, as you can see here. So Grigoris didn't show the resting flow, he just showed the hyperemic flow. But in real practice, we do a resting flow first, which is 10 mils per minute. And that 10 mils per minute will obviously bring about a change in temperature distally where your thermistor is. Maybe, let's say, for instance, 0.5 minus degrees. As Grigoris showed, once that is steady, you then bring the wire back to the ray flow catheter and you measure the temperature of the infusate at the ray flow catheter. And you can see in many cases it's around -3 degrees. And you can see the simple algorithm there at the top that calculates this, gives you basically 10 times -3 over -0.5, which gives you 65 mils per minute. And this is what the curves look like, which I wanted to just demystify. You can put the markers wherever you like, but if you can see on the in the middle where that first marker is, that's where the mixed temperature is stable. If you look to the right, the second marker, that's where the infusate temperature is stable. And you can see we've got a Q in litres of 0.68, so 68 mils per minute. If we then go to hyperemia, all you do is increase the infusion rate to 20 mils per minute. And we know that 20 mils per minute will create some hemolysis, and it will just interact with the wall a little more and give us profound hyperemia, just like adenosine does, but without a PA drop. And you'll see the curves separate as you normally would. And again, the calculation and the way of doing it is identical. You measure the distal mixed pressure, you pull the wire back, you measure the infusate pressure, temperature, and then you work out in mils per minute the exact absolute flow. And this is a hyperemic one. You can see we put the markers at the 2 most stable points in the curve, and we get a mils per minute of 122. And you can see just below the resistance, 685. Now, in reality, the way in which we do it is like this. We do both at the same time. So you do it in one continuous run. So you start with 10 mils per minute, you get a steady state. You increase it to 20 mils per minute, you get a steady state. Once you've got a steady state there with hyperemia, you pull the wire back, you measure the temperature infusate of the 20 mils, then you change it back to 10 mils, and then you stop. And you can see here, you can do the whole thing in about 230 seconds, so about 4 minutes. Completely operator independent, hands off, you can't change anything. And then you, of course, make the measurements at the end by comparing the two curves to give you the relevant temperature and flow and resistance. And this is just taking the two markers at the 2 points, one at rest, one at hyperemia. So in summary, invasive CMD assessment is crucial. It's recommended, as we've heard, by the ESC guidance. It should be performed in a comprehensive and safe manner. I believe continuous thermodilution is the gold standard, but I think it's fair to say it doesn't have the data to support its use yet. There's an ongoing Eurocraft study from Carlos Collet and Bernard de Bruyniguen in Aalst, which will have 5-year data on these patients comparing IMR CFR with absolute flow and resistance, and that will finish probably in June of this year with, say, 1 and 5-year follow-up. It's operator independent, you get flow, pressure, and resistance. And finally, at the moment, there is no mechanism to measure, because the Doppler wire is not available, it's not possible to measure endothelial dysfunction. We have a methodology which will be published next week, which allows, with ray flow, you can infuse low-dose acetylcholine to look at the acetylcholine flow reserve. So I really do think that in time, continuous thermodilution has all of the components we require to tell us what's going on with these really important group of patients. Thank you.
A question maybe on the practical utility of that in patients who have some atherosclerosis. So there will be a lot of ANOCA or INOCA patients who will have 20–30% stenosis. Now, do you perform continuous thermodilution in those patients, and do you see any interaction with the microcatheter across those lesions?
Yeah, no. So, of course, the ray flow catheter does have some real estate. So we know the FFRs are generally about 0.02 to 0.03 lower because of that. But no, we've got huge case series now with impeller-assisted complex PCI, with CTOs, with a large segment in CTOs. All of the latest orbiter studies, which will come out this year, they've all got ray flow that we did. So no, coronary disease makes, from our side, no, we're doing it in STEMI at the moment. So no, you can do it safely, effectively in all presentations. But of course, it's about what you're trying to elucidate. We're trying to, in STEMI, understand microvascular obstruction. So it's just what question are you trying to answer, but there's no reason why you can't.
And about interpretation, because you will have to factor in those 0.02 or 0.03 into the clinical decision making.
But we tend to ignore the FFR is the honest answer, because we're not usually doing it for the FFR reasons. So, but you're right. But if you look at all the studies, all of them show a slight reduction in FFR.
Yeah, excellent presentation. Are there any anatomies or like tortuous LADs or something else that you cannot really use so easily? Are there any limitations on the use of continuous thermodilution?
Rarely is the honest answer. I mean, as Grigoris again demonstrated, you have to have adequate mixing of blood. So you really do want 60 ml at least of ability to mix so that your thermistor is really measuring mixed blood. So again, if you've got a distal tortuous, maybe elderly lady, it will be more challenging to get your wire distally to the vessel. So maybe there are small numbers of patients where this is not an optimal, but it's also not optimal for transit times either. So yeah, there are a few. I can't really think of any others. And as I say, because we've done it in so many different anatomies, including STEMI, we really don't see any major sort of issues.
If there are no burning questions, we're running behind on time. We can discuss further at lunch if that's okay, because we are 15 minutes out of schedule. We stop now for 30 minutes of lunch.